All right, good afternoon and welcome. Thank you all for joining today. My name is Avash Kalra, and I'm going to be giving today's talk, Liver Transplantation Before, During, and After. I'll introduce myself first. I'm on the faculty here at the University of Colorado. I'm a transplant hepatologist. I trained here at the University of Colorado as well in terms of my residency and fellowships, which I finished in 2019. And I was fortunate enough to be recruited back here on faculty last year and started in September of 2021 in this role at the University of Colorado, where I'm also the director of our liver transplant outreach and strategic development. And so as part of that, I will be hosting webinars throughout the course of the year that we'll give you all information on via email as well. And I also travel to other states to do some outreach clinics, including New Mexico and a clinic that we're starting in Montana as well. So with that, I'll go ahead and get started. Thank you all for joining. Like I said, the title of the talk is Liver Transplantation Before, During, and After. I'll also just direct your attention to the chat box within Zoom where you can learn more information about how to get CME credit. There's no disclosures that I have in terms of relevant financial relationships to disclose for this talk. There are slides here. The next three slides are about evaluation, CME certificates, and obtaining ABIM maintenance of certification credit. These slides will be available online, and also you'll get this information via your email for reference in order to complete the evaluation and then obtain CME, and that's for both the University of Colorado Medical School as well as nursing. So today's learning objectives, we have several, and I will try to touch on all of these within the course of the next hour. So number one, identify clinical decompensations in patients with liver disease. Review the indications for liver transplantation. 3, understand the use of the MELD score. 4, identify an approach to alcohol use and sobriety in the setting of a potential liver transplant evaluation. And 5, develop an understanding of the multidisciplinary care involved with liver transplantation. At the end of the talk, and hopefully we'll achieve these objectives, I'll try to leave some room for questions, which you can enter in advance in the Q&A box. So to start, this is a photo of the late Dr. Thomas Starzl, a pioneer in transplant medicine during his time working at the University of Colorado for almost 20 years, but before he went to the University of Pittsburgh for the later stages of his career. He actually intended on becoming a priest, but saw his mother die of breast cancer in the 1940s. And so he decided to go to medical school instead. And we're all fortunate that he did, because 20 years after his mother died, he performed the first successful human liver transplant in 1967, and that was done here at the University of Colorado. And I share this photo also as a reminder of two things. One, the massive amount of people, teamwork involved in success in this field, as you can see by the amount of people in the background. And two, that the era of transplant medicine within the context of the entire centuries-long history of medicine is quite short. Liver transplantation remained experimental throughout most of the 1970s, and it wasn't really until we, as a medical community, made significant advances in immunosuppression in the early 1990s that the modern era of transplant began just 30 years ago. So liver transplantation, first, before. How do people first even get to a transplant evaluation, and what other medical and psychosocial issues do we have to consider? Liver transplantation, according to our governing body of liver disease, the AASLD, is indicated for severe, acute, or advanced chronic liver disease within when the limits of medical therapy have been reached. And certainly there are medical therapies for a variety of etiologies of chronic liver disease. So examples such as steroids for autoimmune hepatitis or antiviral agents for chronic hepatitis B. But sometimes, despite medical therapy, patients with chronic liver disease advance to the point of needing evaluation for a liver transplant. And we'll talk a lot more about that momentarily. I'll mention that recognition of cirrhosis per se does not imply a need for transplantation, but it does require monitoring for complications that may ultimately lead to a need for transplant, such as, for example, hepatocellular carcinoma. Depending on the cause of liver disease, patients have a 0.5 to 3% risk per year of developing HCC. And so we monitor for that with imaging every 6 months. Varices in the esophagus or stomach or small bowel. Hepatic encephalopathy, the accumulation of toxins in the bloodstream leading to a spectrum of changes in mental status. Ascites, development of fluid in the peritoneal space, and its related complication, SBP, or spontaneous bacterial peritonitis, which occurs in up to 30% of cirrhotics. And sarcopenia or frailty, a concept that we'll talk about a little bit more shortly. So patients often ask, well, how bad is my cirrhosis? Or what percentage of my liver has cirrhosis? And we often explain that cirrhosis, which is the development of advanced fibrosis, which includes bridging fibrosis and then fibrotic nodules, occurs throughout the liver, typically, no matter what the cause. And that when someone has cirrhosis, it's more helpful to think of them in two categories from a clinical standpoint: compensated or decompensated. This is a conceptual framework of stages of cirrhosis, 1 through 4, that isn't used universally necessarily, but can be helpful from a theoretical standpoint when thinking about that question: how bad is my cirrhosis? So the progression through the stages, namely the development of varices and ascites, is associated with a significantly increased 1-year mortality. So as you can see, a cirrhotic patient with no varices and no ascites has a 1% mortality risk at 1 year, compared to 57% for patients with bleeding varices with or without ascites. And this is based on a systemic review of 118 different studies from a paper in 2006. Put another way, the 1 year and 2 year survival for patients with decompensated cirrhosis is, as you'd expect, much lower, in the 50 to 60% range, than patients with compensated cirrhosis, with survival rates over 90% for those endpoints. Stretched out to 5 years, the survival decreases quite notably for both compensated and decompensated cirrhotic patients. And this is our patient population that a lot of you see in your practices, and that we see when they're referred with advanced liver disease for consideration for transplantation. We also see many patients in the hospital admitted with various clinical decompensations, and these too are a significant marker of mortality, especially when they require hospitalization. An inpatient database of discharges from 2003 to 2010 in cirrhotic patients in Catalonia, Spain, found that in-hospital mortality for patients with ascites, for example, was approximately 9%. It was even higher for hepatic encephalopathy and higher still, as would be expected, for variceal bleeding, as well as SBP. Hepatorenal syndrome, an end-stage condition that is a consequence of impaired blood flow to the kidneys due to cyclical physiologic alterations in advanced cirrhosis, is the highest in terms of in-hospital mortality. And so what are then the indications for liver transplantation? These are the most common indication listing for transplantation in the United States. And as you can see here, these etiologies for liver disease range from cholestatic liver disorders such as primary biliary cholangitis or primary sclerosing cholangitis, to viral hepatitis and alcohol-associated liver disease. In addition, malignancies such as hepatocellular carcinoma and then less common cancers are indications for liver transplantation. I'll note that that first successful human transplant in 1967 that we mentioned earlier was for a patient with hepatoblastoma. Metabolic disorders and others make the list as well, but the most common indication for liver transplantation now in the United States is non-alcoholic fatty liver disease, and that has changed over time. There's been a decrease in hepatitis C as the etiology for liver disease leading to transplantation over the last several years, and that is related in part to the advances in hepatitis C treatment with direct-acting antivirals. Meanwhile, the burden of alcohol-related liver disease and non-alcoholic fatty liver disease has increased quite dramatically. And while each of those topics is certainly a full-length talk on its own, I hope many of you watching are able to develop a useful clinical approach for those conditions. And part of the goal of today's talk is to recognize when those conditions reach a point that the patient requires a liver transplant evaluation. First, I'd like to mention that non-alcoholic fatty liver disease is an umbrella term that covers a disease spectrum, beginning with steatosis, so fat in over 5% of the liver by definition, which is a condition present in up to a third of Americans. In about 5% of the US population, that steatosis leads to inflammation, a condition that technically requires a biopsy that we often diagnose when patients with steatosis on imaging develop elevated liver enzymes, so the AST and ALT. And typically, initially, the ALT is greater than the AST, would be the classic pattern for non-alcoholic fatty liver disease. Although I will note that once the patients are cirrhotic, the AST often elevates to a greater degree. And that's NASH, when the fat leads to inflammation or non-alcoholic steatohepatitis. The risk factors for these conditions include central obesity, abnormal cholesterol levels, and type 2 diabetes. And in fact, in patients worldwide with type 2 diabetes, it's estimated, and these numbers are staggering, that the prevalence of non-alcoholic fatty liver disease is 55%. It's 25% for NASH and 15% for cirrhosis. Again, that's worldwide for patients with type 2 diabetes. And so it's no wonder then, as the obesity epidemic has worsened over the last 30 years, that particularly in the US, that NASH, which really is a systemic disorder beyond the liver, has become the #1 indication for liver transplantation. Should you screen for non-alcoholic fatty liver disease? Well, guidelines vary on screening from the various liver societies. The AASLD recommends no screening, but EASL, the European Association for the Study of the Liver, does recommend screening in patients with obesity, type 2 diabetes, and the metabolic syndrome. And so it would be reasonable then, based on European guidelines, to recommend an ultrasound to screen for non-alcoholic fatty liver disease in high-risk patients every 3 to 5 years. Long before patients along this non-alcoholic fatty liver disease spectrum even see a hepatologist, they're often managed by their primary care physicians, gastroenterologists, and other clinicians. So how do you manage obesity? Again, that would be a separate talk entirely, but briefly, there are no FDA-approved medications at this time for NASH. There are off-label uses of certain medications, but we do know that the most effective treatment is weight loss. Modest weight loss of 3 to 5% of the total body weight of the patient leads to improvement in steatosis, and 7 to 10% leads to improvement or resolution of NASH. And I've actually started literally pulling out a calculator and calculating this amount with patients when discussing weight loss and an effective way to reach that goal. The AASLD guidelines support lifestyle modifications, which include reducing the daily caloric intake as well as exercise. Roughly 30 minutes a day at least of aerobic exercise in particular, so getting your heart rate up. And lifestyle modifications we know are greater than pharmacotherapy at this time, though certainly that may change in the future. So back off of that tangent and back to thinking about patients with decompensated cirrhosis. So what is the MELD score? The Model for End-Stage Liver Disease score. So it was adopted formally in 2002 as the foundation of the liver transplant waiting list. It initially, prior to that, and still is for that matter, used to predict mortality following placement of a TIP, so transjugular intrahepatic portosystemic shunt. And there are 4 variables that go into the MELD score: the serum creatinine, total bilirubin, the INR, and the serum sodium. Prior to 2016, the serum sodium was not part of the MELD score officially, but after an aggregate of data showing that the development of hyponatremia is a marker of increased waitlist mortality, as well as neurologic dysfunction post-transplant, the sodium was incorporated into the MELD score in 2016. So the MELD score ranges from 6 to 40 from a transplant point of view, though it certainly can calculate to higher than 40 in some scenarios. And though the MELD score's predictive value has been expanded to a variety of clinical scenarios, its most useful and established use is to predict 3-month survival for patients awaiting liver transplantation. So the MELD score range, like I said, is 6 to 40. And the higher the MELD score, the higher the 3-month mortality. So we know that it's at least 90%, the mortality risk that is, when the patient has a MELD score of 40, compared to a 20% mortality for a patient with a MELD of 26. And you can see that after a MELD of about 25 or 26, the 3-month mortality risk increases significantly with each 1-point rise in the MELD score. A MELD of 15 has traditionally been used as roughly the point at which the benefit of a transplant outweighs the risk, meaning that if a patient's MELD score is less than 15, it has been thought that the risk of a transplant itself may outweigh the benefit. But the MELD score by itself isn't perfect, and it's not the only thing to consider. The MELD score has evolved, first of all, in its calculation since its first use, and there are ongoing discussions on how to optimize the use of this metric for a variety of populations, including women, for whom the MELD score, we know, underestimates the severity of liver disease in many cases. And that's for a variety of reasons, including the simple fact that creatinine levels are on average lower in women than in men, which therefore leads to a lower MELD score and therefore underestimates their disease severity. The other point I'll make here is that patients' clinical decompensations need to be factored into the equation when thinking about referral for a transplant evaluation. So the MELD score underestimates risk of death in 25% of patients with moderate ascites. A patient with moderate ascites and a MELD of 11 actually has an equivalent risk of death as a patient with no or small ascites and a MELD of 16. So therefore, the increased risk associated with moderate ascites can inform clinical decision-making and identify lower MELD score patients who may actually benefit from a liver transplant. And so when to refer for liver transplant? What we would recommend is a MELD score threshold of 12, regardless of complications, but certainly if there are. Any complication of decompensated cirrhosis, including ascites, SBP, variceal bleeding, hepatic encephalopathy, portopulmonary hypertension, and hepatopulmonary syndrome, which are pulmonary complications of transplant that actually improve with transplantation, and in select patients qualify them for priority on the transplant list. In addition, cancers meeting certain criteria, so hepatocellular carcinoma, cholangiocarcinoma, and also patients who are sometimes what we call sicker than their MELD score. Patients, for example, with PSC, who have recurrent cholangitis or refractory pruritus. And then considering malnutrition and sarcopenia as a major decompensation of cirrhosis as well, impacting patients' quality of life. I'll mention very briefly that hepatocellular carcinoma is a common indication for liver transplant, and I'm not going to go into the details of treatment for hepatocellular carcinoma or the details of what we call the downstaging criteria. But the key point here is that in 2002, the United Network for Organ Sharing, UNOS, adopted the Milan criteria, which is listed on the left of the screen, as the optimal criteria for selecting patients for transplant due to HCC, or hepatocellular carcinoma. Now, it was subsequently proposed that the Milan guidelines could be expanded based on comparable survival rates that were being achieved for patients beyond the Milan criteria, so what was called the UCSF criteria. But the Milan criteria simply is that if a patient has a single hepatocellular carcinoma lesion diagnosed either radiographically or by biopsy, single lesion between 2 and 5 centimeters, or up to 3 lesions, all less than 3 centimeters, then they would potentially qualify for a standard exception score that prioritizes them on the liver transplant waiting list, regardless of what their MELD score might calculate to. And so to give you an example, if somebody has cirrhosis from any cause, develops a hepatocellular carcinoma, 1 lesion that say is 3 centimeters, and their MELD score calculates to 7, if patients have an evaluation for transplant and are approved for listing for transplant, they can qualify for a standard MELD exception 6 months later, where their MELD score is, for listing on the transplant waiting list, is the median MELD at transplant for that region -3. So for our region, that median MELD at transplant is 30. And so median MELD at transplant -3 would be 27. And so a patient with hepatocellular carcinoma who is a transplant candidate and listed for transplant for 6 months within Milan criteria would have a MELD score of 27, no matter what their calculated MELD score is, unless, of course, their calculated MELD score is higher than 27. If patients are beyond Milan criteria, so have lesions greater than those size requirements, that you can be downstaged, meaning with treatment such as TACE or other interventional radiology procedures, downstaged to within Milan criteria. This covers what I just said about the median MELD at transplant -3. And so that, again, is the listing process currently for patients with HCC. So if you're thinking about referring a patient for liver transplant evaluation, what about age? Age is just a number, but there's more to it than that. It is, after all, a pretty important number. So in the United States, the number of individuals older than 75 years is projected to double to more than 10% of the population by the year 2050. That means that there'll be more older patients with NASH and other causes of chronic liver disease leading to complications for which we would consider transplant typically, such as a high MELD score or HCC. So are we capable of transplanting patients in their 70s? Sure. Yes, absolutely. Of course we are. But the real question is, should we? And when I trained here at the University of Colorado, my fellowship director and now colleague, JP Norvell, would often say that as transplant hepatologists, we're stewards of a precious resource, which are the liver allografts. And as a result, we need to think carefully about risk, even of age, in this massive complex calculation of considering transplant candidacy. So we know that age over 70 years is a risk factor for graft loss and mortality, particularly among patients with a physiologic MELD over 28, with a 1-year graft survival of only 56%. And that risk appears universal. So higher mortality in transplant recipients of advanced age, and studies using both the UNOS database and the European Liver Transplant Registry. This puts it another way, and in a way that you can see quite easily with the bottom solid line of the graph, representing graft survival in patients who are in their 70s, for patients with MELD greater than 28 at the time of a liver transplant. And so, as you can see, a much lower graft survival compared to any other age group. And so as a result, we typically advise against transplantation for patients who are 70 and older, because simply we are weighing risks and benefits, and this is part of the calculation once patients get to their 70s. So now we'll transition to liver transplantation during, or what I mean by that, the time at which the patient is referred for liver transplant evaluation and then undergoes that evaluation. I include this here also as a reminder that we're about halfway through the talk, and I share it as a reminder as well that some might say that the liver is so important that even the brain needs to bring it coffee, an item that incidentally for which there's some data regarding benefits on the liver, but that's probably a story for another day. We're forced to be selective due to the system within which we practice transplant hepatology. And this data is from 2019 and simply shows that the number of liver transplants performed in the US that year was close to 9,000, but there were about 12,000, actually more than 12,000 patients waiting for a liver transplant. There are simply more patients waiting for or needing a liver transplant than there are organs available from deceased donors. We're doing more transplants, but we're also adding more and more patients to the waiting list. And so that gap remains. As you can see here, the wait list really reflects a limited resource. The green line represents wait list additions. The blue bars represent deceased donor liver transplants, which generally have increased through the years. 2018 is the most recent for this data. And living donor liver transplant is a small percentage of the total, clearly, has increased slightly, at least since the early 2000s, but still represents a small percentage of the total number of transplants that are done nationally. And I'll talk more about living donor liver transplant in a little bit. So the evaluation process, these are guidelines taken from the AASLD practice guideline on evaluation for liver transplant. When a patient comes for a transplant evaluation, it is a real multidisciplinary and comprehensive process, often taking at least 1.5 days in our clinic, that includes a variety of factors. And I'll go through these one by one. because I think it's helpful to understand what patients have to go through just to even potentially get on the liver transplant waiting list. So first, financial screening, certainly to secure approval from their insurance companies to even go through the evaluation. A hepatology evaluation, so an evaluation by myself or one of my colleagues to assess their disease severity and confirm their diagnosis, optimize their medical management. They will see a transplant surgeon who, among other things, would identify technical challenges such as a portal vein thrombosis or prior abdominal surgery, and also discuss donor options, including living donor. Laboratory testing, including ABO blood type, drug screens, viral serologies, and others. A cardiac evaluation, certainly including an echocardiography, and then some other form of ischemic cardiac evaluation as well. There's no guideline that makes a specific type of cardiac evaluation required or universal through all the transplant programs in the US. And so that's going to differ from program to program. Our center at the University of Colorado, for most patients, will initially do a coronary CT angiogram as an initial test, but certainly in some patients who have cardiac risk factors or concern for an ischemic a high-grade coronary lesion may directly go to a left heart catheterization at the time of the transplant evaluation. Patients undergo hepatic imaging, including typically at the time of the evaluation, contrasted cross-sectional imaging, such as a CT scan. Patients undergo a general health assessment and are required to be up to date on pap smears, mammograms, certainly a colonoscopy if indicated, and vaccinations as well. They undergo a dental assessment, an anesthesia evaluation, if appropriate, a psychiatric evaluation as well, especially for patients with comorbid psychiatric illnesses or a history of substance use. They undergo a social work evaluation to address potential psychosocial issues, adequacy of their social support system, which is a major topic of discussion for us, even possible effects of transplantation on the patient's personal and social system. Financial and insurance counseling, nutritional evaluation, and infectious disease round out the key components of a transplant evaluation. I'll mention a few common nuances that come up during our evaluation. So first, tobacco use. We stress the importance of complete tobacco cessation. Cigarette smoking is implicated in a number of adverse outcomes in liver transplant recipients. Cardiovascular mortality, for instance, in addition to increased incidence of hepatic artery thrombosis and poor wound healing after the surgery as well. Oropharyngeal and other neoplasms following liver transplant are also linked to cigarette smoking. And some transplant programs make cigarette cessation a condition for listing for liver transplant and require negative serial nicotine screens for documenting tobacco cessation. This is something that you can talk with your patients about before and during the whole transplant evaluation process as a critical component of improving their potential outcome if they're listed for transplant. Nutrition. So the concept of malnutrition and its associated conditions of frailty and sarcopenia have been a really big area of interest in transplant hepatology over the last 10 to 15 years. Cirrhosis is a catabolic chronic illness, often accompanied by reduced appetite. Malnutrition itself leads to poorer outcomes following liver transplant. So patients with a BMI of less than 18.5 were shown in a landmark study many years ago to have worse post-transplant outcomes compared to any other BMI group. And severity of muscle wasting, we know, can be masked by ascites and obesity, especially in those patients we talked about with NASH. There's also a misconception, at least there has been historically, and I think that's changed quite a bit, regarding protein intake. In the distant past, there was a thought that increased protein intake may result in more ammonia production and thereby increase repeated episodes of hepatic encephalopathy. We know, and in the distant past, patients may have even been told to limit their protein intake as a result of that. We know that that really is not a correct practice at this point, because decreased protein intake is likely to worsen their malnutrition state to the point where they may become too weak to even be a transplant candidate. So, for example, if their frailty progresses to the point where they cannot walk, cannot stand, So we encourage increased protein intake in these patients for that reason. There are recently published practice guidelines by the AASLD, now published last year, regarding frailty in the setting of cirrhosis. And we know that frailty is a systemic condition. And when I say frailty in this case, I'm referring to physical frailty that leads to increased risk of decompensation, decreased quality of life, and increased risk of death, as well as adverse post-transplant outcomes. Frailty has been strongly linked with mortality in both the ambulatory and acute care settings, as well as the post-transplant setting. And so the AASLD now recommends that all patients with cirrhosis should be assessed for frailty with a standardized tool, both at baseline and longitudinally. So in practice, there are a number of objective frailty assessments that are available to use. We use one called the Liver Frailty Index, or LFI, pioneered at UCSF and has expanded to many other transplant programs now. And we use this as part of the evaluation. So during their 2-day transplant evaluation, patients will undergo formal frailty testing with this Liver Frailty Index, which includes items such as hand grip strength, time to do repeated chair stands, as well as a balance component. And frailty, as measured by the Liver Frailty Index, is associated with a nearly 2-fold increased risk of death in a study of over 1,000 patients with cirrhosis awaiting liver transplantation. In practice, it can be used as an opportunity to improve those outcomes. So if a patient is frail, perhaps they cannot be a transplant candidate until they improve that frailty, and the Liver Frailty Index can be used to monitor that longitudinally. So for example, with increased protein intake, increased exercise, or physical therapy formally as an outpatient to improve those outcomes. How about bone disease? Osteoporosis is frequent in patients with cirrhosis, up to 55%. So if you have a patient going for liver transplantation and you want to wish them luck, do not say break a leg. Osteoporosis reflects common risk factors. So inactivity, inadequate nutritional status, hypogonadism, chronic cholestasis, and alcohol excess. And bone densitometry, so by a DEXA scan, for example, is indicated before a liver transplant, given the frequency of osteoporosis and cirrhosis, as well as determining vitamin D and calcium levels. We also know that bone mass diminishes in the initial 3 months following liver transplant due to high-dose steroids, at least that are used in many programs up front. Most programs, including ours, will try to limit steroids and try to taper patients off of steroids in the early transplant period, but certainly increased steroid use in that time after transplant can increase fracture risk. The psychosocial assessment of liver transplant candidates is critical and often requires the input of not only our social workers, but often psychiatrists and/or addiction specialists. So we and others have recently started to use as a clinical tool the Stanford Integrated Psychosocial Assessment for Transplant, or SIPAT. The point being that this is a formal way to provide a psychosocial assessment, a scoring system actually, on a variety of domains that we, as transplant hepatologists and transplant programs, have always evaluated. This sort of, like I said, formalizes and actually gives a score to this that we can use in our discussion about transplant candidacy. And it looks at these domains. So patient readiness level, that includes compliance and adherence to medical recommendations. Social support system, including the functionality of that social support system. Psychological stability and psychopathology, as well as lifestyle and the effect of substance use. I'll transition then with the mention of substance use to talking a little bit about alcohol, which is obviously a common etiology of both acute and chronic liver disease. It's a common indication for transplant, and a topic that, as I said, ties in very closely with the psychosocial assessment for many of our patients. The incidence of alcohol use disorder is increasing, and it's a frequent consult question for us from within our center and from outside centers, asking whether a patient may be a transplant candidate with the question of how recent their alcohol use has been. We're faced then with this question of whether to consider transplant for severe acute alcoholic hepatitis. which is a separate condition from decompensated alcohol-associated cirrhosis. Especially as more and more data becomes available showing that transplant outcomes such as survival and alcohol relapse are similar for the two conditions. So alcoholic hepatitis, just briefly, is a severe inflammatory state of the liver that can lead to portal hypertensive complications, including variceal bleeding and ascites. It can lead to liver failure and death in many patients. And it's typically triggered by sustained heavy amounts of alcohol over a shorter period of time, such as months to a few years, compared to the chronic alcohol use that we typically see leading to cirrhosis over the course of several years or decades. And this is the patient who's hospitalized with profound jaundice, bilirubin of, for example, 30 or 40. Sometimes it's their first presentation of liver disease. The American Consortium of Early Liver Transplantation for Alcoholic Hepatitis, Accelerate AH, published data in 2018 showing that post-transplant outcomes for patients, for selected patients, I should say, transplanted for alcoholic hepatitis was similar and acceptable to patients with other causes of chronic liver disease. So survival at 1 year of 94%, 3 years of 84%, and sustained alcohol use of 10% at 1 year and 17% at 3 years, which are numbers that I'm not sure if are not surprising to some of you listening, but actually we know that despite all of the interventions that we have pre-transplant, there is a substantial percentage, unfortunately, of patients who have some degree of alcohol use after transplant. And so these numbers are actually thought to be somewhat in line with the expected results. So this is a topic that continues to evolve. And as a result, more patients nationwide are considered for transplant with much shorter periods of sobriety than maybe historically were allowed. A period of 6-month abstinence, which in the past, there was this concept of the so-called 6-month rule, which never was a rule, by the way. This was just a guideline that many transplant programs may have used. But 6 months of sobriety is an arbitrary number. It does not predict future sobriety. Mandatory sobriety times, actually, we know from data, encourage some degree of dishonesty. And many of the patients have high mortality risk within that 6-month period. And so I want to emphasize the point, there is no 6-month rule for sobriety for transplant. There certainly are recommendations for how to carefully select patients with alcohol use disorders. So who to consider for alcoholic hepatitis, first of all. So again, not including patients with alcohol cirrhosis. We may consider patients for alcoholic hepatitis who are medically refractory, so who, for example, did not respond to steroids if indicated. Candidates must admit to significant alcohol use simply because patients denying alcohol use either don't have alcoholic hepatitis or are in denial. And then the patients have to engage in the process of sobriety and committing to it. So engaging in rehab and counseling prior to and immediately after transplant. And they cannot be so sick or confused, so high-grade encephalopathy, that they're unable to either tolerate dialysis or they're not able to engage with our transplant team. So we know that rather than focusing on a defined period of time, like 6 months of sobriety, it's better to think more about the weighing of protective factors versus negative factors in order to carefully select patients with alcohol use disorders. Protective factors being social support, improved self-esteem, understanding the consequences that alcohol use had negatively on their health and life. And all of that leads to insights to their addiction. Negative factors certainly would be repeated attempts at rehabilitation and repeated return to alcohol use despite that. Social isolation with lack of support, presence of psychotic disorders or personality disorders. Certainly these are negative factors that would be weighed by the transplant committee. So again, to re-emphasize the point, there is no 6-month rule. Patients need to demonstrate insight and commit to abstinence. And the patient cannot be so sick that they are unable to engage with our psychosocial team. So once patients are listed for transplant, again, they've gone through the transplant evaluation, no major medical or psychosocial comorbidity has been discovered to warrant declining for transplant. And they're listed on the transplant list for deceased donors based on their MELD score. And though I didn't say it specifically earlier, with our sickest first policy in the US, the patients with a higher MELD score are prioritized and so are at the top of the list. Patients with lower MELD scores are lower on the list. But how do patients get transplanted once listed? And so first I'll mention that the MELD score at the time of transplant varies by geographic region. So one of the more controversial aspects of liver transplantation in the US is the geographic variability and the degree of sickness based on the MELD score in candidates undergoing deceased donor transplants. And so this study, actually from 2011, showed that a patient with a MELD of 38 had an 18% chance of obtaining a transplant in 90 days in one region versus an 86% chance in another region. And so clearly the policy had to change, and in 2020 it did, changing the prior system of regional boundaries and replacing it with this concept of nautical distribution zones from the donor hospitals. And I'm not going to go into the complexities of this today, as it's outside the scope of what I'd like to talk about. But essentially, candidates with the highest medical urgency have broader access to organ offers before less urgent candidates who are closer to the donor hospital. And the thought is that this will improve the geographic disparities that we know exist or existed prior to the implementation of this policy. Still, we know that patients, especially those with poor socioeconomic factors and decreased availability to see a transplant center, are at risk for sort of being left out of this equation. Patients with lower MELD scores, other populations, including African Americans, including women for the MELD score reasons I mentioned before, are not as well served by the MELD score, which, like I said, is not perfect. And so we have to think about other ways to get these patients transplanted when they require a transplant. And so living donor liver transplant for selected patients offers an opportunity to avoid the complexities of the liver transplant waiting list. And so a living donor, sometimes related, but often not, donating roughly half of their liver to an adult recipient, or a smaller left lateral segment to a child. We know from now plenty of data that there is a survival benefit of liver donor liver transplant in the MELD era. So living donor liver transplant for patients with both a MELD over 15 and below 15 have a significantly lower probability of death, those are the gray lines, compared to patients not undergoing transplant. Those are the black lines with increased probability of death, with the x-axis representing years from donor evaluation. We also know that there's an equivalent survival rates with living donor transplant compared to deceased donor living transplant. Living donor liver transplant provides access to transplant for all candidates who are in need, independent of their MELD score, but particularly if their MELD score is low. And by low, I mean relatively speaking, so under 20. Patients who, for example, are decompensated or have indications for transplant, but may not be as competitive for deceased donor liver transplants because simply of their MELD score. Up to 20% of our transplants at the University of Colorado are living donor liver transplants. And this is in large part due to the clinical and surgical experience regarding this, and also evaluating donor safety throughout that process. My colleague, Dr. Whitney Jackson, is our medical director of living donor liver transplant. And then in addition, our transplant surgeons, including Dr. Elizabeth Pomfret, who's our chief of transplant surgery, Dr. James Pompaselli, who's our surgical director, are among the most experienced transplant surgeons in the country in terms of this procedure. It allows our patients, who are, again, carefully selected for this, the ability to get transplanted before becoming critically ill. And it also has improved recovery rates and increases the donor pool for many of these patients. So lastly, we've done the before and the during, so liver transplantation after, and I'm just going to have a few slides on this. We monitor as a transplant program for early and late complications, certainly, but the reality is the vast majority of our patients do extremely well. So greater than 90% survival at a year. And obviously, as I mentioned, we did the first liver transplant in 1967. And so we have a vast population now who have undergone liver transplantation. Early complications after transplant are managed and recognized typically in that early period while patients are still in the hospital or just recently discharged. And that includes biliary complications like strictures or leaks, vascular complications like a hepatic artery or portal vein thrombosis, and then complications related to the function of the graft, including acute cellular rejection. The later complications is what I'll talk a little bit more about, because these are the types of complications that we would manage in conjunction with many of you watching today. In terms of, for example, metabolic diseases and malignancies. So in practice, metabolic complications are common, and liver transplantation is a known risk factor for that. So common complications after liver transplantation, many of which are related to the required immune suppression medications that patients need to take to prevent rejection. So metabolic complications including diabetes, hypertension, dyslipidemia, and obesity. Co-management of these complications really is critical, and that would be our goal as a transplant program, to work with patients' local clinicians to manage these. The AASLD notes that this is a busy slide, obviously, but I direct your attention simply to the top line, that the prevalence of the cardiovascular risk factor of metabolic syndrome in patients beyond the first post-transplant year is 50 to 60%. And again, metabolic syndrome includes patients who have any three of hypertension, obesity, dyslipidemia, and diabetes. The incidence of de novo malignancies is also higher among liver transplant recipients versus an age and sex-matched non-transplant control population. So the cumulative incidence of de novo cancer after transplant increases from 3 to 5% at 1 to 3 years to 11 to 20% at 10 years after transplant. And the most common are squamous and basal cell skin cancers. But we also know that cigarette smokers, for example, are at increased risk for developing lung cancer and oropharyngeal cancer. And the rate of colon cancer is increased in patients undergoing transplantation across population, but especially in patients who are transplanted for PSC, primary sclerosing cholangitis, because of the often comorbid risk from inflammatory bowel disease. And so when we see these patients after transplant in our post-transplant clinic, we spend a lot of time talking about the management of the metabolic syndrome that I mentioned on the prior slide, as well as monitoring for de novo malignancies, including a skin exam every year, wearing sunscreen, and other screening modalities for the other types of cancers. So today we discussed a variety of topics intentionally broadly related to the 3 phases of liver transplantation: before, during, and after. One of the great parts of our job in transplant hepatology is that as time has gone on, we have a lot more patients in the after phase as we transplant more and more patients. Over 100 at our center every year, which is the highest in the region by far. So many patients who would not have survived without the modern era, without the modern advances, I should say, of transplantation and post-transplant care. And so some conclusions. As I discussed early in the talk, consider screening for non-alcoholic fatty liver disease in high-risk populations. NASH is the #1 indication for liver transplant in the United States. Identify clinical decompensations in patients with chronic liver disease, and this should prompt early referral for liver transplant evaluation if appropriate. The MELD score predicts waiting list mortality and continues to evolve. There is no 6-month rule of sobriety for patients with alcohol-associated liver disease, but demonstration of insight and engagement in sobriety efforts, as well as support, are critical. It's appropriate to prepare patients for the multidisciplinary nature of a transplant evaluation. And living donor liver transplant frees patients from the wait list with excellent outcomes. I'd like to acknowledge in closing the entire University of Colorado liver transplant team, including our nurses and coordinators. Certainly would acknowledge my colleagues, the rest of our transplant hepatologists, all of whom were faculty when I was a fellow, and so are mentors to me. In particular, Dr. Burton, who's our medical director, and Dr. Foreman, who have been clinical and really life mentors for me for almost a decade since I started residency here. I mentioned Dr. Jackson's our medical director of living donor liver transplant. I also would like to thank her and Dr. Chris as I borrowed some slides from prior talks in the preparation of this talk. And I'd like to also acknowledge Lindsay Carter, our administrative assistant, Christy Click, our CME office, and our IT department for their help arranging this webinar. Our current division director of GI and hepatology, Dr. Stephen Edmundowitz, and Dr. Pomfret, who I mentioned earlier. I'd like to acknowledge them for recruiting me back to the University of Colorado in this role. And then John Gutowski is our executive director of transplant services and has been helped with our outreach efforts, including in other states. Like I said, I do a clinic twice a month in New Mexico as well to see patients there closer to their communities. This is how you can get a hold of us. There's a 24/7 attending hepatologist that you can reach on the doc line. I've left the phone number there for our clinic referrals, and that is me at the bottom with my email address and cell phone. Please reach out if we can help any of your patients. And now I'd like to answer some questions. This is my oldest daughter from actually just a couple days ago wearing her full PPE at our house. This is what happens when you grow up during a pandemic. Thank you very much for your attention and really appreciate the opportunity to speak today. I'm going to stop sharing my screen so that I can see all the questions that have come in. Okay, let's see. Okay, and thanks again to all of you for let's see here. Sorry, give me 1 second. Okay, so I'll try and go through as many of these as I can in the remaining few minutes we have. So one question that came through the chat. So how does a transplant center decide which tool to use to evaluate patients, like CyPAT for psychosocial assessment? It's a great question. I think that for the transplant evaluation process, it's important to try and be as objective as possible. The gravity of the situation is not lost on any of us within a transplant program in terms of deciding whether somebody's a transplant candidate. We know what the consequences are if somebody is declined for transplant. We know that in the past, there may have been more subjectivity to these types of things, like, is the patient frail? Do they have social support? These types of issues may have been harder to address objectively. As time has gone on, with more focus on making sure that these things are evaluated objectively, there are more and more scoring scales. I think that the important thing to do is to look for scales that have demonstrated some type of effective outcome. So I mentioned the liver frailty index. There's a lot of data for that. That's why we use that. The CyPAT is admittedly a newer one, but it's now available, and we're using it really recently. And I mean recently, as in within the last month, just started using it to try and assess patients' psychosocial comorbidities. I think it's just important to be up to date with the literature, see what's out there, see what's effective and easy to use for the transplant program, and always be willing to evolve. For the next questions, let's see here. So once patients have hepatorenal syndrome, does this affect eligibility for liver transplant? No, not necessarily. I guess it depends on, just like anything in transplant, it depends on a variety of factors, including just how sick they are, how frail they are, what their comorbidities are. But simply having hepatorenal syndrome, so again, this condition that is really at the end stage of a cyclical nature of physiologic changes affecting blood flow to the kidneys, that often leads to patients requiring renal replacement therapy or dialysis. patients can, depending on their dialysis needs and where the creatinine is, if you ever calculate the MELD score, you might notice that there's an opportunity to check if somebody's on dialysis or not. That does actually automatically make their creatinine 4 for the MELD calculation, and that will increase their MELD score. And so it may prioritize them in some way, but no, it does not affect eligibility per se for liver transplant. Other questions, let's see here. So for patients with HCC within Milan criteria, why must the AFP be under 500? What is the reason behind that? It's a great question. Again, HCC as a topic, it would be a separate webinar, I suppose, perhaps in the future. But briefly, so as I mentioned, the AFP doesn't have to be under 500 necessarily to transplant somebody with HCC, but it does have to be under 500 to prioritize them for transplant with that exception score that I mentioned, where the MELD score is given as a 27 for at least for our area. And that's because when as we evaluate data and look at selected patients with HCC that should have, to be fair and equitable, similar outcomes for transplant as anyone else undergoing transplant, it's been shown that patients with poor tumor biology, so AFPs that are, for example, over 1,000 despite treatment, are much more likely to have microvascular invasion, subclinical spread of tumor that then is diagnosed post-transplant once patients are immune compromised. And of course, that can lead to metastatic complications. And so to minimize that risk, we know that getting their AFP under 500 to get that exception score is the best way to do that. The next question is ulcerative colitis a complication of liver transplant? So no, not necessarily. So ulcerative colitis may be a comorbid condition, or Crohn's disease for that matter, especially in patients with primary sclerosing cholangitis, but by itself, not thought to be a complication of liver transplant itself. Just want to make sure I'm answering all these questions. What is the reason only very few living donor liver transplants are done in the US? The results are in some other countries, such as Japan, are really good. Another great point. Thanks for asking that question. So for a variety of reasons, living donor liver transplant, in terms of the proportion of transplants done, may be higher in other parts of the world. So in some areas of Asia, for a variety of reasons, there are more living donor transplants done than in the US. A couple of those reasons may be culture. So number one, cultural differences. So in some countries, especially in Asia, the general population is less likely to be willing to accept a deceased donor. Again, that's for cultural and sometimes religious reasons. And therefore, living donor transplants are done for the spectrum of MELD scores, even patients with acute liver failure. As a result of more living donor liver transplants done, probably a higher percentage of surgeons at all centers, as opposed to just a few high volume centers in the US, are trained in that. And many surgeons in the US actually go to Asia to be trained in living donor liver transplant. But great question. And that's a part of the gap that I think needs to close as we go forward in the US as well. And then it looks like the last question is, what would you expect from an internist to do prior to sending a patient for evaluation for transplant? Great question. I think that the most important thing would be, after recognizing the need for a transplant and starting to talk to the patient about it, make sure that the patient's up to date with their preventive health screening, things like mammograms, pap smears, vaccinations, but especially for patients who have alcohol use disorders, have multiple relapses in the past. Talk to them even before the transplant evaluation of starting alcohol counseling. Set the expectation that that's going to be required by the transplant program. For patients who are obese, BMIs over 35, discuss weight loss and via lifestyle interventions like diet and exercise with them. Really, those are the minimal things to do prior to a transplant evaluation. And our goal as a transplant program would be to work with primary care physicians, GI docs, and APPs to work together to support patients on the transplant waiting list and improve their outcomes post-transplant as well. I'll also, as we wrap up here, just direct you that Lindsay Carter put in the chat box information about CME and NCPD nursing credit, and that information is also on our website. And I guess one last question rolled in, so I will address that quickly before we wrap up, as it is 1 o'clock. So how soon, so from Jessica Ryder, thanks for asking. So how soon after an alcoholic hepatitis admission should a transplant center be contacted? Patients are often too sick or too well to get to you, from my experience. And so certainly, if they are too well and they're able to get out of the hospital, that would be ideal. We would like patients to, in almost all circumstances, be discharged from the hospital, engage in sobriety, and have a negative PEth test, which is a topic I did not discuss, but phosphatidylethanol, which is essentially a breakdown lipid product of ethanol use that sticks around in the bloodstream for several weeks after at least a moderate amount of alcohol use. And so that test should be negative, at least prior to sending most patients with alcohol use to us for a transplant evaluation. When it's their index hospitalization, so they've never been told they have a problem with alcohol use, it's the first time they've ever presented with alcohol, they have great insight and support, that still may warrant a call to us to discuss a transplant evaluation if they're not improving, again, with steroids or other medical treatments. All right, again, I really appreciate all of you joining. Reach out to us if you have any questions. I gave you my contact information, so please contact me anytime. Thanks very much and have a great rest of your day.